uses emerging technology to advance global health, and her work is all about the intersection of health, emerging tech, and design, focusing on turning big ideas into tools that actually work for the people and the society. She's also been in Kenya for a very long time, and in line with my Swahili lesson of the morning, she's going to give us one Swahili word as well that we should all learn and take forward today. So ladies and gentlemen, with a round of applause that is loud at the back, loud in the front, and loud for all of you watching us online, help me welcome to the stage, Miss Ann Stage.
Swahili word? Okay, Lala Salama. But I hope everyone stays awake for our panel. I'm sure they will.
So Lala Salama means good night, yeah?
Sweet dreams.
Sweet dreams, sleep well. So we need, it's sort of opposite day today.
Exactly. All right, well, welcome everyone to our Full-STAC panel. I'll call up our amazing panelists right away because I think you want to hear from them, not me. So we'll start with Dr. Garrett Mell of WHO. Welcome to the stage. Next up, Dr. Fred Hirsch from Google. Oh wow, you're very far away. Let's do Steve Wanye of Helena and IntelliSoft. We'll have Dr. Joyce Wamiswe of the Digital Health Agency of Kenya, one of the visionaries behind the digital health superhighway here, which we'll hear about. And last but not least, the guru Rubaiyat Khan, the thought leader from Endless Health. Thank you so much for being on the panel today. So just a few quick framing comments here. There are like two trends that I think really underpin the conversation today. The first is the funding contraction that we're all experiencing. I think it's not news to anyone that the funding landscape is extremely difficult right now. Said more bluntly, the destruction of USAID and the destruction of lives and livelihoods coming out of that. I think we're just at the beginning of seeing the repercussions of that kind of terrible decision by the US government. The second trend, though, at the same time is the rise of AI. So a new technological revolution that is really poised to change everything about the way we develop software, the way we develop products, the types of products that are possible. And one thing, as we invest in AI, as we invest in all of these different tools and chatbots and new ways of working, one thing that I'm really worried about and have started to see is that we might be kind of taking a step back and losing focus on some of the fundamentals, some of the lessons that we've been trying to learn over the last 10 years of digital health. And the purpose of this panel is really to go back to first principles, because there's a better way to develop digital health, right? There's ways that we can build open ecosystems, we can build aligned products, we can build open standards, open content, open architecture, open technologies, so that all of the tech products work together in a country, they ladder up to a bigger vision, and that it promotes innovation from the private sector underneath kind of this public sector, the public sector rails, so to speak. So that's really the focus of the conversation today. It's all about this full-stack vision that actually started at the Global Digital Health Forum in 2021 with a paper. I encourage everyone to read it if you haven't. But to kick off this important conversation, I want to start at the global level and then slowly go deeper and deeper into country specifics. So let's start with Garrett Mell from WHO. So you've been at this for many years at WHO, really thinking about what are the standards, how can your member states actually build digital health systems that work for citizens in those countries, and would love to reflect on, what has that journey been like? Where are we today, and where do we need to go?
Great. Thanks a lot, Anne, and it's a pleasure to be on this panel. I think in the last year or more, in fact, I think a significant number of changes have happened. I think, Anne, you alluded to the changes in overseas development aid funding, which really have impacted, I think, how our member states at WHO see the role of and a need for being able to establish the underlying foundations that they need to be able to self-sustain, self-finance, not only the digital side of things, but also the broader health sector. I think we saw from a survey that was conducted at WHO with our member states, we saw at least 50 countries in March that had already been impacted on their information systems. And that was everything from servers stopping to passwords being not available, to information systems going offline, to data sets not being available. A real crisis, I think, that I think gave a lot of us pause, and really, I think the first principles thoughts that you shared, Anne, in the intro were things that we were recognizing in member states really wanting to get to this point of resilience, getting to the point of having an essential set of digital and data infrastructure. We have seen over the last several years a number of goals that countries are trying to achieve. They're trying to ensure that, for example, every health provider has access to a health record for the patients they see. They have access to decision logic that helps them to ensure they're referring or giving the right care protocols, that every patient has their access to their own record, that they have insurance that makes it accessible for them to seek care. These kinds of goals require foundational systems that interact, that share content, and that are based on a set of content that is evidence-based and relies on a set of services that governments themselves can provide as digital services linked to a set of different applications that are available in a broader ecosystem. As an organization, we see the role in the Full-STAC as ensuring that our member states have content that is in a digital format that they can then make available or adapt into the country specifications. We call that smart guidelines. It's one open content standard in the Full-STAC. It provides not only the requirements documentation, but also mapping to FHIR, and increasingly we're looking at how the calculations that are represented in those specifications can not only be used with AI, but also can be used in testing frameworks and testing harnesses. We also recognize that countries are moving over to digital public infrastructure, and they're looking outside of the health sector to provide the foundational pieces of identity, financial transactions, and data sharing in order to build that resilience, that financial sustainability that they want. My colleague Derek Munene, you may have heard, is helping countries to do and ensure that a number of different agencies are helping to be coordinated around the needs of government, around the Global Initiative on Digital Health, which is really an operational mechanism of the global strategy. And I'll just say that's a coordination mechanism to make sure that the needs of our member states are at the forefront of the kind of technical and financial assistance that all of a larger ecosystem within the country, but also outside the country can help them to achieve that resilient, essential digital and data infrastructure. So I think we've seen those changes. I think Full-STAC still remains an important foundational way of thinking about that. And Anne, back to you. Thank you.
No, that's awesome. Thank you so much, Garrett. I think WHO clearly has been setting this global agenda for a while, but the way that it actually, where the rubber hits the road is actually in countries, right? We need countries to be leaders in enabling this digital health vision. And that's why I want to really give the floor to Dr. Joyce. She's been one of the visionaries behind the Kenya Digital Health Superhighway, which I think is one of the pillars of excellence on the continent. I think there's a lot we can learn from you, so I'd love to hear from you about your experience getting to where we are today and kind of how you're thinking about Full-STAC and how do you think about the government's role in enabling this broader ecosystem, this innovation ecosystem as well.
Okay, so thank you, and thank you for having us on this panel. So that's an interesting question that I always get asked, and it's been a journey, that's what I can say, first of all. So it always starts with defining the vision. I know it sounds so repetitive, it's the one thing that I'll keep on. Hello? Sorry. So, okay, I hope can go on. Maybe it needed some AI. So anyway, it's the one thing that we keep on saying. So as government, we define the vision. And a few years back, we defined this vision and said we are going to have all systems that want to be part of the health ecosystem speaking through a health information exchange that we then dubbed the Digital Health Superhighway. To explain that concept to people outside digital health was not easy. I recall when we were taking our Digital Health Act and the regulations through the parliamentary process, we kept on being asked, which other standards do you want to put beyond what is typically known as the ISO standards? And that's when I realized, the word standards has many meanings. But outside this room, I can tell you, when you say standards, people think of ISO standards. But there are so many other standards that are required to get to what we call optimal digital health transformation. And one of those was defining how this digital health superhighway would look like. So we were able to say there would be, 6 or so registries, and there would be some specialized registries. Of course, the first 6 would be about identity management, basically of the patient, the healthcare worker, the facilities, terminology concepts. And then we even had, we were like, okay, we also have the community health promoters, and we realized we needed some sort of registry for them. There are people who felt it should be part of the healthcare worker registry. Others were like, no, CHPs are a bit off from healthcare workers. Yes, they are part of the health ecosystem, but let us look at them a bit differently. And then at the time when we were dreaming up all this, we were looking at this as a fairly, if I may use the word easy, but lightly, a fairly easy thing to deliver. Today, if I'm to draw the famous slide that we call the Digital Health Superhighway slide that denotes all the things that we are doing as per the vision, there are things that I would add to that Digital Health Superhighway. One of the things that we've realized is if you're having a social health insurance foundation like what we have right now, there are other registries that we need. Because we want everyone to, for example, be reading the benefits matrix the same way, the tariffs the same way. We realize those are not things to have out there, but they should be part of the public good that is called the Digital Health Superhighway. Another one that is quickly rising to that position is clinical modules. For example, the HIV module, the NCD module. Should everyone be building their own module in their systems? We definitely need a place where we are having modules that are aligning to the treatment guidelines in the country, for example. I quickly think of the IMCI guidelines, that's the Integrated Management of Childhood Illnesses guidelines. That's not something you want to have out there. It's a part of a public good. So on, and clinical decision support system is another one we are thinking about, of having it as part of a public good. So I would definitely draw that slide in a different way, given that we have, every day we are learning about what needs to be part of the digital health superhighway. Sometimes I've thought maybe I'm pushing it a bit far, but when I ask the teams in the country, Steve and others, they say, yes, that makes sense. The other thing is, when we talk about integration to the health superhighway, I came to this space thinking it was going to be plug and play. But alas, it wasn't. The initial facilities, the private facilities that were bold enough to be guinea pigs, to integrate to our digital health superhighway, I started counting. I thought it would take 2 weeks. At 8 weeks, I stopped counting. And I realized this thing has to be looked at differently, because we were trying to make the systems, so beyond the 6 registries, now we wanted them to now go to the side and have their own way of interpreting the SHA benefits and the tariffs. But ideally, those are now, as I have alluded to earlier, those are things that should be part of the superhighway. So it's a learning curve, but at the end of the day, from where I see it, technology should be something that makes life less painful. So I'm always asking our technical teams, is there another way of doing this? Is there a painless way, if I might say? And the digital health superhighway is definitely one of those painless ways, if we get it right. And it's one of the ways that ensures that nobody is feeling threatened, that if they will come up with a system, that government will squash that system. So we are allowing innovation, but innovation in a way that says, but use this foundation, so that we ensure that we meet the overall goal of having health data portability, for example. So we want innovators to be comfortable, but they should ensure that they are able to integrate to the digital health superhighway, but not in a painful way. So amazing. I can talk a lot, but
I mean, I could let you go the whole time, because it's so great to hear from actual experience in the country, in Kenya. You were talking a lot about innovation and about building this ecosystem. A few of us, Garrett and I and Fred and Rebecca, were commenting earlier about the amazing group of innovators that have come together around the superhighway, not just ones that are part of this consortium, but also kind of a wider community of young talent, of new startups that are starting to emerge, that are actually able to use this digital health superhighway and kind of enact this vision in real time. Steve, wearing your 2 different hats, one Helena and one IntelliSoft, would love you to comment about the role of kind of community building, capacity building that you've been driving across the region, but then also in your role in IntelliSoft, how you've seen this ecosystem in Kenya evolve, because I know you've also been working closely on the superhighway.
Thank you very much, Anne, and it's good to be here again. I mean, those are interesting questions. I think Joyce has laid out the foundation really well. I think wearing my Helena hat, where we currently work with about 20 countries. So we've got national health informatics associations in about 20 countries who are our members. And each of those associations have on average about 300 people. So we focus a lot more on sort of policy type of stuff. So working with the likes of Dr. Joyce at the Digital Health Agency. And one of the things that we are finding that is of interest to Helena, and I think can transform the foundations of digital health, is I think this concept of standards is not the easiest, but yet it's probably has the most transformational impact if done correctly. And the challenge we've been finding is how do you quantify the return on investment of standards in a way that the ministry actually understands, and they're able to see that if they don't do it that way, they're probably going to stand to make huge losses. And I'm looking at Merrick because there's one slide in one of the courses that Merrick ran for a long time about the exponential increase of costs if you don't use standards. So you've got 2 systems, 3 systems, 4 systems, and that's probably been one of my great saving slide when I'm talking especially to ministers of health. And I think being able to also put a number to it in terms of the actual amount of shillings, francs and dollars that a ministry could actually incur if they don't follow standards. So I think the biggest challenge we've had as Helena through working with many countries is articulating the return on investment. So if you don't use standards and all, what do you really, what costs are you going to incur? That's the first one. And the second one is enforcement. So as Joyce has mentioned, it's all nice and easy to say, let's adopt standards like fire, ICD-10, Law Inc. and all that. And there are technical ways of doing that, I think, fairly easily. But when you start talking about doing that at a national level, it gets really, really complicated. So for example, in Kenya, through Dr. Joyce's leadership, we're developing Kenya's National Fire IG, the implementation guide, that is supporting the priority use cases for Kenya's Ministry of Health, which is one, electronic claims, continuity of care, local health security and all that. And it's going pretty well. The luck we have through Helena is that we are the regional affiliate partner to HL7, so we're able to get the best technical support from HL7's organization. And more importantly, away from the technical side, Joyce's leadership at Digital Health Agency has made it easy to adapt because standards are now called out in Kenya's legislation. So it's moving from being a nice to have, whether you're a private health vendor or working in public health, there's a pathway towards adopting standards, but you also know that at some point it's mandatory. And so we're finding that sort of community building around standards. With government leadership, it's a lot easier. But I think the traditional community of practice where, let's hang out, let's catch up, let's have a convergence workshop and all that. I think without leadership and this being ingrained in legal documents, whether they are policies or actually the law, adoption is not as easy, and it's a very difficult pathway, even though we've shown the case for why that is possible. So that's what we're doing at Helena. It's going pretty well. One of the initiatives we have is called Africa on Fire. And really happy that, the colleagues that I'm here with in the panel, Fred, Garrett, Joyce, Rubayat and all, are really part of that and supporting that a lot, looking at Jing and others who are in the audience. So it's this notion of how do we accelerate capacity around fire at the various levels. So I know Derek might be in the audience, but there's a famous triangle of, strategic people at the top, and then all the way down you've got the frontline healthcare workers. So you've got those sort of differentiated capacity building initiatives, and you're using fire obviously because of its potential in transforming the sector, but we're also looking at other standards as well and working closely with others who are doing that kind of stuff. And if I could switch hats a little bit, I also run a company called IntelliSoft, and I think going back to Anne's point, and using example of what you're doing in Kenya, I think the concept of a public-private partnership model is great. But I think until you get to a point where the political leadership of a country understands the role of private sector in healthcare, it's very difficult to operationalize it in reality. For those of you who run companies, it comes down to whether you can pay your bills, you can pay your staff, and break even and things like that. And so if government doesn't, through law and through the right political leadership, enable that environment to work, it's very difficult for private sector who are doing amazing work to make their contribution in healthcare through digital health. So I think in Kenya what has happened with the passing of the Digital Health Act that Joyce spoke about, it's pretty much opened the floodgates. So some of the work we're doing with the likes of Safaricom in Kenya, which again was designed deliberately by government to have telcos involved as well because of data transportation. Having the Digital Health Agency setting the scene and laying out the environment and staying out of the way and allowing private companies like ourselves to come in and actually build and then they govern. It's a model that I think we're figuring out how we can take that to other countries that Helena is working in. And lastly, one of the discussions we're having, I think as Anne was mentioning, was it's really unfortunate, I think, as a global community in digital health, I don't think we've done a very good job of having entrepreneurs, especially in health tech, understand the assets that are available in global goods. I talk to my fellow businessmen and women in Kenya and other countries, they get amazed at how much is available. For example, whether it's the open health stack, suite of technologies, or OpenMRS, DHIS2 and all that, they get amazed at how much is available that would save them a lot of money in terms of the products they build and they roll out in the markets. So once again, I think we need to do a better job because the net effect of that is that you end up getting technologies that are very expensive, not very well built, that introduce a lot of security risks because no one was paying attention to safety, trust, and things like that. Yet we've got a lot of that available in kind of like the global goods collection. So I'll take a pause there. And
No, that's great. One thing you started talking about is this kind of the global goods that are available. I think one of the challenges with global goods in the past has been maybe this over-indexing on full solutions and maybe a little bit less on the enabling architecture, the components that actually can be replicated and used across. You also called out Jing and the Google team, so a good segue to Fred Hirsch, who's been really leading Open Health Stack at Google, which is a great example of a big tech company working with partners and actually trying to co-create that vision for what useful architectures and global goods might contribute to the community. So we'd love to hear about how that journey has been going and where you're going now.
Great, thanks. Well, thanks, Anne, and terrific to be here. And just reflecting on your earlier comments, this kind of conversation about the full-stack approach really kicked off at GDHF, I think back in 2021, and kind of has evolved really to the publication that came out, I think, a couple of years later. And it's just amazing to see the progress, right? Every year we've been back here talking about it, seeing the implementations that are really kind of coming around it. So, just a shout out to everyone that's been involved, and it really is a big kind of community effort. And so, our role, if you like, within that community has been to think about these like open technologies. So the full stack is open standards, technologies, architectures, and content. And so Open Health Stack itself is a response to that, if you like. It's a suite of open source components and resources. These are digital public goods that are really designed to make it easier for developers to build what we think of as next-gen digital health solutions, right? These components can be incorporated into new solutions, but equally can be used in existing solutions. And I think it's been a fantastic example, we think, of a good kind of public-private partnership, collaboration between Google, Health, WHO, ecosystem, community of developers, and others. And I think it's been about how do we, what's our role in helping to achieve this kind of shared vision of, person-centric digital transformation for health, but at the same time, how can we unlock this local innovation? And I think that's kind of key, right? So what's unique in a way about Open Health Stack is this focus on building enabling infrastructure. So it's developed, these components are designed to meet the unique needs of developers, building in particularly low resource environments where you need offline capabilities. You can't necessarily use a cloud. And it's really all about, how do we reduce the barriers? How do we reduce the kind of barriers to entry, the complexity? And in that process, kind of drive down the costs of innovation and enable then, local innovators to be solving local problems, right? We were talking, we've got this, kind of submerged iceberg kind of image, and if you put that in your mind, if you think of an iceberg, what Open Health Stack represents is the what's below the surface. We don't want everybody to kind of maintain the full stack, so let's understand what those problems are. Let's build those, as a community, let's support those, and then ensure that there's enough space for that innovation. So I think overall it's been going very well. We have a really kind of growing community of developers that are building, with different components of Open Health Stack, seeing these solutions now kind of come into the field, be deployed, tools in the hands of healthcare workers really delivering the care. And of course, in order to enable that, we've been working with Helena, with WHO, with the community on capacity building, right? So I think this is where the rubber hits the road. We have these technologies, we have these opportunities, in Kenya with these, the top-down, kind of creating that enabling environment. So now how can, local, tech innovators participate in that? So we're very involved in running kind of different workshops. Some, we produce a lot of the materials, but then our local developer experts like Stephen's team or the Nawi team or others here in Kenya, for example, but in other places as well. So kind of investing in that capacity building aspect too. And I think what we really see, we can't leave here without talking about AI, and that really is, a very exciting opportunity. We started by focusing on standards and interoperability because, as you've heard, it's key to being able to achieve this kind of person-centric care. We also realized that it was really important in terms of the quality of the data, which is going to feed into AI in the future. The future is now. So more recently, we've really been thinking about how do we apply that same approach to AI for health, and particularly for global health. And so earlier this year, our sister team within our kind of Health AI research group launched what's called Health AI Developer Foundations. And this includes our open weight, medically tuned model called MedGemma. And I think it kind of honors that spirit of how do we put out some of these technologies and then work with the community to understand what are the gaps, what are the barriers, how do we safely and effectively see this be deployed. We're kind of actively learning about what those opportunities are. I think we're kind of, as a community, in the early days of this. Obviously, we're seeing a lot of exciting projects, but I think there's a lot of opportunities to really think about what are those enabling capabilities, what's going to make it easier for innovators to be using, developing, deploying, and ultimately scaling these types of AI technologies. And so Google.org has been supporting this as well. There's a number of partners that are now being funded with grants to really, do some really exciting work. And it's great seeing how this approach, which I kind of start to think of as almost like a DPIs for health approach, is really starting to take shape. And if I reflect on that, what I think is kind of key to this maybe, new, how kind of going back to first principles, but thinking about like, what does this future look like? I think it's pretty simple. I think it's three things, right? I think it's about, first really understanding the barriers and the opportunities. So building, kind of connecting with the community, understanding where the problems are, where the opportunities are. Thinking about enabling infrastructure as the product. I mean, obviously there's lots of different kind of capabilities, but I think as we think about how do we bring these technologies to life, what is that enabling infrastructure? And then really, doubling down on the capacity building. We really want to see, those skills being developed. I mean, it's a very exciting time, I think, to be in technology, to be a developer, and really how do we as a community support and enable that? So I'll finish by saying, it's a big tent. I think there's a lot of opportunities. It's been exciting for us from a technology perspective to kind of lean in and to be able to play a role. And we're really excited about seeing how this is going to be taken forward.
Thanks so much, Fred. We got to minute 16 without mentioning AI, which I think is a big accomplishment these days. But we are going to spend a little bit of time now delving a little bit deeper into AI, building on what Fred was mentioning. Rubaiyat from Endless Health has been doing a lot of thinking about what this AI ecosystem might look like, to build on what Fred was saying, thinking about infrastructure as the product, and how do we build tools that are replicable, so we don't have millions of different chatbots for different vertical diseases out there, but that we're actually building something that's aligned with the vision that the rest of the panelists laid out. So over to you, Rubaiyat.
Thanks, Anne. Chatbots have become the bane of my existence these days. Just to zoom out a little bit on the AI question, I think it's really useful, as one of my friends, I don't know if Matt Berg is here, but he frames AI as a superpower, right? Kind of like the OG superpower of Jesus turning water into wine. It's a superpower that we now have to do a lot of things differently that we just did not have the ability to do before. So for example, we can turn the workforce scarcity question, which has plagued health systems forever, into an abundance equation where every health provider, whether it's a community health worker, a pharmacy, or a family caregiver, can be upgraded to use AI to provide much better quality care and standards-based care, right? So we can think of enabling self-care. Anne and I talk about that a lot. In terms of enabling the 99% of healthcare that happens in the home, that people do day to day in their own decisions, how do we kind of amplify that and make sure that that contributes to health outcomes? So there are a lot of these really systemic, transformational opportunities that AI provides, which I don't think we're fully scratching the surface yet. So I think of ourselves as almost like akin to the early 2000s of the GPS era. So the GPS became widely available in the year 2000. But then Uber, the first really like transformational use of GPS, came in 2010, right? So it took 10 years for us to really understand how to apply GPS to transforming systems. So I think that kind of thinking will take time to evolve and for us to really absorb the full potential of AI and into our health systems. And I think there's a real opportunity for countries to leapfrog now into the AI era. I think doing things the way we have done before and just incrementally improving it using AI is, I think, short-selling ourselves. There's a lot of ways to completely rethink and reimagine how health systems operate. And I hope that a lot of countries will take that opportunity to leapfrog. But just taking that water and wine analogy, like maybe a step too far, we learned the hard way in the early stages of the digital health era between maybe 2010 and 2016 that you need the plumbing infrastructure, right? You can't just go into a piece of land and build a bunch of sinks and faucets and bathtubs and expect them to work. They need the plumbing to connect them in order to work properly, which is why we kind of entered into the full-stack era and talk about standards and architectures and reusable components. All of this came about through that experience. I think if we want the wine to flow through our taps, we still need those plumbing pieces, right? Like we cannot ignore that and move into the AI era, which is why a lot of the countries like Kenya who are really leading the charge on this, India has done a fantastic job of setting the DPIs. Brazil has really wonderful kind of basic architectures in place. I think those are the foundational pieces that are going to be essential if we are to take full advantage of the AI era. And unfortunately, what we see now is most countries are actually not there yet. Despite years of effort, we are still far behind. And I really worry that will widen the digital divide. And we are not going to truly be able to leverage AI the way we want to. I think the other point that I'll just mention is that this does require a lot of leadership vision, as Dr. Joyce was mentioning, but also governance capacity from the government in order to be able to do this. And in the current financing climate, we can't ignore the elephant in the room that like who's going to pay for these DPIs, right? There's a lot of questions for many countries. DPIs are expensive, and that's the foundational piece that's necessary before we can even leverage the full stack approach. So who is going to fund that? I think the really interesting question for me, which I don't have an answer for, is how do we do this in countries that don't have the financing, don't have the right governance infrastructure? Are there other ways of approaching interoperability and open standards that are more decentralized, federated, more people-driven, that don't rely on, let's say, shared health information exchanges at the government level, which are, of course, difficult and complicated to do. So I think those are some pieces that we still need to figure out, but I hope we do because AI is the most transformational technology of our time, and I hope we are able to take advantage of that opportunity. Thank you.
I think that's a perfect way to end the panel section, but would love to open it up to the audience for some rapid fire questions if we're allowed to do that. I think we are. Otherwise, we can keep talking up here. But if anyone has a question that you can keep pretty brief and address it to one of the panelists, they'll try to answer it fast, and we'll see how many we can get through. The gentleman in the front.
Yeah, we are increasingly facing these challenges of having multiple applications, multiple tools without interoperability. Now, these global standards, who is going to make it mandatory or who is going to support for this OpenStack standards? So what is the way forward? This is my simple question. Thank you.
Who wants to take that? Garrett?
I think what we've heard, and I think what we're seeing in many countries is the government is defining a specification which enables the interaction between the innovations that may be happening in the private sphere, if you will, with the underlying infrastructure that's happening and the payment and claims mechanisms and the social and beneficiary schemes that exist that the government defines. And Dr. Joyce, I know you can speak more to this than I can, but the aspect of defining a specification, you have done that, and also making available the sandboxing environments that enable systems to plug in and test their solutions against that specification, and then knowing that they are conformant to that, that gives them the ability to ensure they're getting payments, claims, and other aspects and benefits from a larger infrastructure. I think the government has a role, and those outside of government have a role, and an interoperability standard can play a role in bridging both of those and ensuring that aspect of health data portability is part of that. Thanks.
Dr. Joyce, do you want to weigh in on governance and how you did it in Kenya, or how you're doing it?
Yeah, so if I reflect, I've actually been, Garrett, I was reflecting on what you were saying and asking, did we get where we are because somebody said we must? I don't think so. Partly, I don't think so. It's the main reason why we have standards right now is because we had done so much trying to, let's say, have interoperability work to the point it reached a point we were like, okay, how else can this thing work? And we then had to say, okay, at some point we would like systems to speak to each other. And then we got to understand that to speak to each other, there are certain things that need to be defined. In 2010, we had already started defining our, let's say, EMR standards. But it was out of the sheer confusion that was there in the country at that time. We had small systems, big systems, but they were not speaking to each other. They were not delivering what they were supposed to deliver. So I guess for us as a country, we got to where we are because we've learned that where there's chaos, you don't move so much. Then the other thing that now we did was, instead of, you will not find in our Digital Health Act that it is mandatory to do this, but you will find statements like, for every provider, you are expected to update a clinical encounter every 24 hours. How do you do that if you're not conforming to certain standards? So we look at it that the people in the sector must identify that this is good for them to comply to deliver the bigger story. So that's how we did it. Yeah, thank you.
I just maybe want to make one comment also, just to clarify something. So first of all, I think one thing that's unique about FHIR is that it is an open standard. There is no cost to use it. And then when we talk about Open Health Stack and what we're doing there, these are technologies that are open source and free to use, that then makes it easier for developers to leverage these standards in the solutions that they're building.
Awesome. I think we answered as well as we could, but we can talk after. Maybe one more very, 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 very quick question from the gentleman back there. Oh no, this person. Okay.
All right, thank you. Thank you. My name is Chamnorwa Shandiri, Zimbabwe. Thank you so much for so much insightful discussion and conversation. So my question to the panel is all about data security. I know we talk about full-stack application, deploying them. We've got electronic community health and everything. So what are we doing really about data security, mostly the protection of personal information? Just imagine we've got the application, we've deployed it to the community there, and the data that we process is very sensitive data, mostly the health information. Just imagine if it falls into the wrong hands, what measures, what protocols, what technological, organizational measures, probably from the top, maybe who are we doing to ensure that all these systems that we are working on developing are robust enough to ensure that we protect the data that we work with. Thank you.
Yeah, I mean, I think I can answer briefly based on what we're doing. So I think there's plenty of technical standards to protect data and secure data, and I think others can speak more about that. But what we're doing is I think on the legal and regulatory side of data governance and data protection, Africa CDC, who I think their mandate is very well known, they're currently working on developing a continental health data governance framework. Dr. Joyce can speak about Kenya's data governance framework that's already been developed, and I think that spells out to the details of everything you've asked. But more importantly, because I think that can, to give that legal teeth, most of them we're seeing they're being underpinned by data protection acts, which are pieces of legislation. So for example, like in Kenya, there's a Data Protection Act that was developed by the government, and it's an act of parliament, but it covers all types of data. Then the Ministry of Health, through work that Dr. Joyce led, needed to customize that for the health sector. And so there's a health data governance framework that is based on law. I think the danger is that sometimes you find very good data governance frameworks, but they're legally unenforceable. And so the issues of risk and all that are still there. But I think on the technical side, for example, looking at Open Health Stack that Fred spoke about, and many other global goods, there are data security experts that are working towards ensuring that those meet the standards that are defined in law and regulation. But Dr. Joyce can speak about that a little bit.
Yeah. I think I understand the question he's asking, because we asked ourselves a while back. One of the things is we have like the client registry. So when there was this talk of can we use the open, what do you call the word, full stack, open concept, people were like, so we are going to be opening our client registry to people out there. I think that's what you're asking. But the whole concept is, if you're told to build a client registry today, you can do it two ways. You either start from scratch, defining how this client registry is going to look like, and you struggle through, yet there could be someone who's already thought about it, then you pick what they have thought about, but now you adapt it to your country. Isn't that what we are talking about on this stage? So that is what Full-STAC is all about. So there are people who have done the hard thinking, they have collected lessons learned here, and then when now you're building that client registry, you pick that and then now adapt it. Does that mean that your client data is out there? No, because you're going to still put the necessary security features that are needed to ensure that data is safe. Yeah, and of course now accompanied with all the legal and regulatory documents that are there that are being implemented. I've explained from a very layman perspective, but I would want to hear whether I've done a good job.
That was perfect. And I think a great note to end on. Thank you so much to the panelists. That was fantastic. And I think we're over to you.